I'm Cliff Dupre. I'm with the Salute America team. We're based at UT Health San Antonio. This is the next webinar in our series of webinars called Let's Improve Health in South Texas and Beyond. Today's webinar is Tipping the Scales Toward Health. Our moderator is Dr. Amelie Ramirez, and Dr. Ramirez is Director of Salute America, and as well as the Institute for Health Promotion Research at UT Health San Antonio. She spent over 30 years directing research on communication to reduce chronic disease, obesity, and cancer health disparities among Latinos and all people. She's also Associate Director of Cancer Outreach and Engagement at the NCI designated Mays Cancer Center at UT Health San Antonio. Thank you, Dr. Ramirez.
Thank you so much, Cliff, for the introduction. And thank you today. We have just an amazing panel that's with us here. And we thank you all for making time to join us and to discuss this important topic with those who are listening today. We know that diabetes, heart disease, and cancer are major chronic illnesses that we find in our community, not only here in South Texas, but also in the U.S. And we're interested in learning more about what are driving increases in this disease. For our Hispanic population, we find that cardiovascular disease and cancer are neck to neck in terms of being some of the leading causes of death for our communities. Oftentimes, we find that obesity is a major driver for these chronic illnesses. In fact, we know that 42% of the U.S. population is either overweight or obese, and at about 20% of our children are already battling this between the ages of 2 and 19, are already showing signs of obesity or being overweight. But it's also a worldwide problem that we need to be concerned with. Over 1 billion individuals, adults and adolescents and children are already being affected by obesity. And this number is expected to continue to grow. So we really want to have a discussion with our panelists to see how can we begin curbing this tide of obesity so that we can learn more about the non-medical drivers of health that are impacting obesity, and so that we can start to reduce these diseases that are hurting not our families and our loved ones. We are delighted to have our panelists today that can help us identify these opportunities to address obesity in our community and to fight it the right way and to find easier choices and the right choices for our communities. So what I'm going to do today is I'm going to briefly introduce each of our panelists, and then we'll have them all come and each one of them will say a few words, and then we'll go into an open discussion about the issues that we're working with. So first of all, I'd like to begin introducing Dr. Ramon Cancino. He's our Executive Director of Primary Care here at UT Health San Antonio. Dr. Carolina Solis Herrera, she is Chief of Endocrinology Division and Medical Director of the Endocrinology, Diabetes and Obesity and Metabolic Health Clinics at RUT Health San Antonio, and Dr. Julius Hunter, who is a Senior Management Coordinator for the Diabetes Program under the City of San Antonio Metropolitan Health District. And our first speaker today to start off our discussion and represents our webinar sponsor. We are here today because of Genentech, which is a biotechnology company and a member of the Roche Group. We are pleased to have with us Dr. Pierre Theodore. So with Genentech, Dr. Theodore helps address issues addressing novel pharmaceutical technologies among our communities of different backgrounds. So Dr. Theodore, can you share with us a little bit of your thoughts and the role of Genentech in helping us fight obesity?
Thank you so very much, Emily, and thank you all for joining today. This is an absolute pleasure for us at Genentech to really be supportive of organizations and providers that have boots on the ground of addressing complicated issues related to metabolic diseases and oncology. And so it's a true delight for us to be here to support today. And I'm also honored to represent Genentech, as you mentioned, a pharmaceutical company that's based in South San Francisco. We are very committed to the prospect that we believe that breakthrough science really should reach all people, regardless of background and zip code or socioeconomic status. And we strive to ensure that our innovative therapies are available to all for their benefit. The thing about today's conversation that from my perspective is so valuable is that for a complicated condition and issue of metabolic disease and the co-association with downstream effects of oncology, orthopedic disease, public health issues, and so forth, requires multiple perspectives to be brought. Primary care, endocrinology, public health, industry, to really create a sort of interconnected approach to complex health challenges. At Genentech, we're committed to being a part of the solution through several key initiatives. First of all, in terms of our clinical research, we want to ensure adequate representation so that our treatments are proven to be effective for all patients that eventually they will serve. Secondly, and this webinar is an example, it's important for us to collaborate with community-based organizations, academic medical centers, and providers that themselves are addressing the barriers to care, everything from transportation to language to healthcare literacy. And as you mentioned, understanding the social drivers of health. And third and finally, we are making significant investments in clinical research and development to explore innovative approaches to metabolic health conditions, all the while recognizing that obesity, diabetes, oncology, it requires a comprehensive management strategy that's beyond any single intervention. In particular for this webinar series today, we think this is important because it embodies this collaborative approach. We need to bring together these forces of academia and public health and industry. And that is the only way we can ultimately tackle these sorts of complex health challenges. So I'm very excited about the perspective today. We at Genentech and Roche, our parent company in Basel, Switzerland, are delighted to support this and continue to look forward to working together with you to tip the scales towards better health for all communities. Thank you for allowing us to participate.
Oh, thank you so much, Dr. Theodore. I mean, as you mentioned, this is a very complex issue, and it takes the different areas of science, as you just mentioned, to really address the issue, so that we can hopefully begin to make better progress over the years to come, and to really curb the tide of obesity. So thank you very much for those comments. Now I'd like to go to Dr. Cancino. Can you describe the burden of obesity in South Texas, particularly among the Latino population, and what are you seeing contribute to this issue?
Great. Yeah. And thank you for having me, Amelie. Really honored to be part of this prestigious group. And so, yeah, we are here today because obesity remains a critical public health concern for South Texas, especially in our Latino community. Our region is burdened by some of the nation's highest obesity rates, often reaching between 40 and 45% in certain counties. And with Latinos comprising the majority of the population in South Texas, our community disproportionately experiences obesity. And as was mentioned before, this is a complex issue with interconnected factors that span social, economic, cultural, and environmental areas. One of the primary contributors to high obesity rates are non-medical drivers of health. So factors like economic instability significantly limits access to nutritious food choices and high-quality healthcare services. Many families in our community face financial constraints, pushing them toward affordable but calorie-dense and nutritionally poor food options. Economic hardships also reduce opportunities for physical activity and limit access to preventive healthcare, which exacerbates the obesity crisis and can do so for years. Additionally, South Texas communities often exist within food deserts themselves. These are areas lacking convenient access to supermarkets or fresh produce markets. This limits availability, and forces residents to rely on convenience stores and fast food establishments, which again drastically reduces the opportunities for healthy eating. The lack of accessible, nutritious food creates a challenging environment for individuals and families and perpetuates the cycle of poor nutrition and obesity. I would add, too, health education and awareness represents another critical area needing attention. there's often insufficient outreach and limited culturally tailored educational programming available for our patients in our communities. Language barriers and varying health literacy levels further complicates efforts to provide essential information for nutrition, physical activity, and obesity prevention strategies. Another relates to behavioral issues in our community. Dietary changes over recent decades have further intensified obesity risks. Traditional diets, rich in fresh produce, whole grains, and lean proteins, have increasingly been replaced by highly processed, calorie-rich foods and sugary beverages. And convenience, affordability, and often aggressive marketing tactics have significantly influenced dietary shifts and dietary behaviors in our community. And then again, we need to recognize cultural preferences for carbohydrate heavy meals further compounds the problem. And there is often a social aspect with food that is very cultural specific as well. I want to touch again on physical inactivity, which also contributes to obesity rates in the region. Many of our communities lack adequate infrastructure, such as parks, gyms, recreational centers, safe walking paths, essential for regular, safe physical activity. And our climate sometimes makes it hard, right, to go outside and exercise as well. And these consequences of obesity extend far beyond weight alone, contributing significantly to numerous health conditions. We'll talk about type 2 diabetes today, obviously, but there's also increased risk of cardiovascular disease, hypertension, high cholesterol, heart disease, and even stroke. Obesity significantly heightens the risk for various cancers, including colon cancer, breast cancer, pancreatic, kidney, and especially in our community, liver cancers as well. And finally, I'll touch on, Amelie, the mental health implications of obesity should not be overlooked. Conditions such as depression, anxiety, decreased self-esteem frequently accompany obesity, reducing an individual's quality of life and complicating efforts toward weight loss and health improvement. And so, I'm a primary care physician. I believe that primary care teams play a critical role in addressing obesity within our communities through consistent preventive care. Primary care teams can uniquely be positioned to screen, monitor, collaborate with specialists, and intervene early for our patient population. And so increasing access to primary care and healthcare in general, strengthening primary care efforts to remain vital in creating sustainable, community-driven solutions to obesity is ultimately one of the factors that will help improve overall health outcomes across South Texas.
Wow, that was a lot. And thank you. And again, it just illustrates how complex this disease is and how demoralized an individual who's trying to lose weight can become, because there are a number of factors that are impacting them that are contributing to this disease. And so we need to help our communities find those tools that are going to help them address this issue. So thank you so much, Dr. Cancino, for your comments. Now I'd like to go to Dr. Solis Herrera. Can you please share the importance of obesity management and what's new in the arena of treatments for diabetes and obesity? And what are the complications?
Absolutely. Well, first of all, Dr. Ramirez, thank you so much for the invitation. Thank you to this wonderful panel for joining us. Thank you to Genentech for their support and everybody that is joining us. We have almost 100 people online right now. So thank you for taking the time to share this important information. And I hope that the information that we talked about today, you're able to spread and disseminate to the rest of your community, your trainees, your colleagues, so that we can become one voice and work together in this tremendous pandemics. So as you all have mentioned very well, obesity is associated to over 200 comorbidities. So although we think about 4, 5, 6 things, according to the American Board of Obesity Medicine, it's over 200 complications. And yes, of course, many of them metabolic. We always think about cardiovascular disease, which is the leading cause of death in patients with obesity. Obesity also increases mortality in general. And patients with a BMI of over 40 can live up to 10 years less than the average American. So managing obesity is very important because it improves quality of life and it also prolongs life. So that everybody can complete their bucket list and be able to enjoy their retirement. One of the important things that we also need to talk about is that having obesity is, yes, associated with multiple complications. And as Dr. Cancino mentioned, the psychological complications are very important. And so now that we know that obesity is a pandemic that is transitioning to our children, it's very important that we utilize medications for weight management that are approved for children 12 years and older so that we can help them become healthy adults and not adults with premature diabetes, adults with premature cardiovascular disease, risk of cancers, etc. So some of the new therapies out there, GLP-1 receptor agonists, which are hormones that we produce in our own body, but that pharmacological levels create an effect of satiety, can help us lose weight. All these hunger and satiety are managed in our brain, in our hypothalamus. And so this is where these drugs act and they send a signal of satiety. They slow down your stomach. So you're able to eat a smaller amount of food, and that combination helps you lose weight. These medications have been in the market for several years. They've shown to be safe and effective. And other studies in even younger children started at 6 years old. So very promising. And we'll talk a little bit in the future about the pipeline because the pipeline is very rich and very promising. However, what's really important that hasn't been mentioned is to open the conversation. So if we take out the pediatric population of the United States, 1 or 2 adults have obesity. 1 or 2 people that we see in our clinical practice have obesity, and most of them qualify for medical treatment. And there are multiple studies that have shown that medical treatment needs to be combined with lifestyle intervention, diet, exercise, and behavioral therapy, if appropriate. So if we don't find that underlying cause why the patients are gaining weight, grief, disease, being sedentary, working from home, if we don't resolve those root problems, then it'll be a harder battle to help them with their journey of improving their weight. The other thing is that it's important to bring programs to the schools so that they learn how to eat healthy, how to cook healthy meals, and they bring that information home so that they can demand to their parents also to have those healthy foods over there. So a global pandemic, we need to open the conversation with our patients gently and candidly, because we need to remember that in average, an American that comes and wants to discuss with you obesity has had, in average, 7 tries of trying to lose weight, trying to do everything correctly, diet, exercise, medication, and for some reason it didn't work out, or they had another baby, or they got laid off, or something happened in their lives. And so we need to help them and also be their cheerleaders, because patients need a lot of support. They know they have a medical problem, they feel tired, they already probably have complications, including mechanical complications, sleep apnea, back pain, knee pain, etc. And so it is important to be their cheerleaders and remind them that it is an important genetic component. And so it is not a problem about willpower. It is a problem about genetics, where hormones that cause hunger are being higher or surpassing the hormones that give satiety. So it is on us to open the conversation with the patients and not expect the patient to come to you, because we have a lot of work to do. Thank you.
No, thank you so much. And thank you for addressing the issue of willpower. So many people feel defeated because they feel that they can't, they've tried these different approaches and it's just not working. So thank goodness that we have these new medications and approaches to helping us address this issue to help it become more manageable. So thank you so much, Dr. Solis Herrera. And now I'd like to move over to Julius Hunter, Dr. Hunter, who recently just got his PhD a few weeks ago. So congratulations on joining the group here, Dr. Hunter. We really are excited for you and look forward to working closely with you. So, Dr. Hunter, can you share with us, your work that you've been doing with Metro Health and really trying to address diabetes prevention here in San Antonio?
Yes, sure. Thank you, Dr. Ramirez, for allowing me to have this opportunity and be a part of this so needed discussion here in San Antonio. I bring you greetings from our city leadership and from Dr. Claude Jacob, who is our public health director here at San Antonio Metro Health. And we, as the city of San Antonio, we're invested in the health of our community and providing resources for this community in order to get healthy, to prevent chronic disease, and to prevent and delay type 2 diabetes. We are our diabetes program is a part of a comprehensive suite of programs that were created to address chronic disease, to include our Poor Vita program, our community nutrition program, our Mayor's Fitness Council, and our Healthy Neighborhoods program. In 2013, the Diabetes Prevention and Control Program was created to address the high prevalence of diabetes that we see here in our community. And of course, we know that the majority of those people that have been diagnosed with diabetes also are overweight and obese, and that is contributing to their diabetes. And so the program was created to provide health education to the greater San Antonio community. It is a program that is facilitated by peer educators in the community. And so the educators go out to our different community centers. We're in libraries. I like to make the joke that, hey, if you're someone and you have a couple of neighbors, you can even get a cat or a dog to join, and we'll be there to provide education and resources so that you could prevent and delay type 2 diabetes and also all other types of chronic diseases. And so that program was created for health education, and we have 5 unique workshops that we offer to the San Antonio community. First one I would like to highlight, which is one of our newest, is called the Diabetes Garage. And that workshop is specifically geared towards men. It uses car analogies in order to explain diabetes self-management. Because one of the things we realized in looking at the data was that we had a plethora. We had so many, and we're thankful for that. We have so many of our ladies that were attending our workshops, but I would say it was about 90 to 95% ladies and maybe 5%, and that's probably generous, men. And so we realized that we needed to reach out and figure out a solution to where we could reach more men in the community, and we've gotten a great response for that workshop. Another workshop that we offer that is also a diabetes self-management workshop is the DEEP program. It's a diabetes empowerment education program, and one of the reasons that we decided on that specific workshop, again, and some of the themes that have been talked about before, was we wanted something that was culturally relevant and for our population, and that honored our cultural foods and our ways, but also was able to communicate how to prevent and delay.
Like we just lost Dr. Hunter a little bit there. Okay, Dr. Hunter,
Can y'all hear me there?
Yes, we can. Yes.
Oh, I'm sorry. I don't know what happened there. Sorry about that. But yeah, so we adopted a DEEP program, and then our two other workshops, diabetes prevention, the National Diabetes Prevention Workshop, and also the healthy living workshop that deals with all chronic disease. And so again, we are excited to provide that resource for the community. And I know we'll talk a little bit more as we get into questions, just about my research for my dissertation and also some of the strategies that we have found to be really effective in helping people prevent and delay type 2 diabetes, but also manage chronic disease.
Oh, that's awesome, Dr. Hunter, and very creative in using the garage analogy to try to get our men in. I don't know why they're so hard, but we find those in almost every education program, where we get more women than men, and they need this information too. So we're so glad you've come up with some of those creative approaches. Well, now I want to make sure that our panelists know that please put your questions in the chat. Our panel is open to addressing some of the questions that you might have, but I'll kind of get us started. So, Dr. Canzino, what are some of the common challenges that you see among your clinic patients for trying to manage this complexity? I mean, some of them are coming in for obesity, but they may also have diabetes or, high blood pressure. And so, and you only have about 15 minutes to help address, some of the issues. What do you do in your practice to address some of these most common issues?
Yeah, no, thank you, Amelie. I need to learn more about the diabetes garage though, because that could be one of the things we send our patients to. Yeah, I'm a family medicine physician, and for those that don't know that are in the audience, so I see children and adults in my primary care practice here at UT, and in that stead, I frequently encounter several common challenges when managing patients. The first issue, and we've sort of touched on it, is just the stigma associated with obesity these days, right? Unfortunately, it continues to carry negative stereotypes that can deeply impact both the quality of how we communicate with our patients and also the patient's readiness to engage in treatment. Many of my patients may not be psychologically ready to embark on some of the lifestyle changes or decisions on medication management therapies that could help them. And this could be based on previous negative experiences with weight-focused healthcare, things that they heard from their friends or their community. But there's always a reason why folks feel the way they do. And this really does underscore the importance of approaching these conversations with sensitivity, empathy, and understanding. And one of the reasons I like primary care is because it also focuses on the longitudinal relationship I'm able to have with patients. So while patients may not feel ready or safe to have conversations about their weight on the first visit, maybe by the third or fourth visit with me, we're sort of ready to embark on that journey. I've already sort of touched on a number of the non-medical drivers of health that impact our patients and their community. And, many traditional primary care settings are not equipped to help patients address those non-medical drivers of health. If there's time, I can talk about some of the things that we're doing here at UT Health, but I know many clinicians struggle with helping patients address those non-medical drivers, which have such a direct impact on a patient's perspective on and success with, their weight or their diabetes. Medication management and adherence can sometimes be an issue. Some of the medications that are out there have side effects or costs, and we have to take time to talk with our patients about the benefit of some of these medications and help patients manage the risks, benefits, and costs of these medications and the side effects sometimes associated with them. And so that often can be a challenge for some patients, especially, again, if they're not ready to go on this journey. Healthcare nowadays does continue to have sort of fragmentation across different types of doctors, different types of care settings, and especially if a patient's care team is not on the same page about the patient's goals for weight loss. or treatment of their chronic diseases, sometimes patients are getting hearing different things from different doctors. And so one of the benefits here at UT Health is because we're an integrated health system, we're talking all the time about our shared patients, but we often take care of patients who have specialists outside of the system. And it's very important for us to have open communication pathways with them. And then finally, effective chronic disease management really requires robust data for us to be able to understand, are we doing better than we were last year as it relates to a patient's weight, their diabetes control, or their blood pressure control. And so we lean quite heavily on our ability to track that data so that we're able to demonstrate to patients the successes and challenges that they've had and attach some data to those outcomes as well.
Wow, very complex, and all of that in a short period of time, to develop the rapport with your patient and
That's
then
right.
the follow through. And it's that follow through. We need them to continue coming and
Exactly.
and participate in those visits. So thank you so much. I'd like to ask Dr. Solis Herrera, what obesity treatments do you see that are on the horizon and that would, you see making a difference?
Yeah, absolutely. So first of all, I guess we should come up with a definition of obesity. So obesity is a chronic inflammatory disease that requires long-term therapy. And so patients sometimes think that they're gonna need medication for 6 months and then they can stop the medication and just continue with the lifestyle. But many studies have shown that that doesn't work. Most patients regain approximately 80% of their weight if they stop the medication and the efforts. That's why it's important that they know that it's long-term therapy. The latest, we've been studying obesity medications for over 100 years. The latest medications in the market are semaglutide and tirzepatide, which are second-generation GLP-1 receptor agonists. We talk a little bit about the mechanism of action with satiety and decreasing the amount of food that you consume. They're excellent medications. They've shown to be very safe. And the other important thing that they have shown recently in cardiovascular outcome trials is that they decrease major adverse cardiovascular events. So not only they help you lose weight, they protect your heart, and some others have shown that they also protect your kidney if you have diabetes, so they're cardiorenal protective. And that translates in more years of life and less chances of complications of those 200 complications that we talked about. So these medications lower your total body weight somewhere between 15 and 20%, which is a great number. The magic number is 10%. So when we're treating obesity or doing weight management, we need to try to get to that at least 10%, and everything after that, like I say, it's gravy. So that will significantly help our patients. What is in the horizon? So many things. Right now, again, we have semaglutide and tirzepatide, which are injectable weekly drugs, but there are multiple medications, including oral GLP-1s as their peptides. It's very difficult to manufacture them because it's like having oral insulin. It gets destroyed immediately in the stomach. But phase 3 studies have shown that orforglipron, for example, is GLP-1 receptor agonist that is oral and that is showing over 20% of weight loss. Also, there's a concern about losing muscle when you're losing weight. So we recommend more protein and weight-bearing exercise. However, there are also studies where they're developing molecules that help muscle growth regulation so they can be combined with these drugs so you don't lose so much muscle. But the most important thing is long-term therapy. So the 4 pillars of weight management need to be used together because it's very easy that the patient gives up and then just stops the medication. Of course, right now, some of the barriers are also insurance coverage. And this is why these programs are important, because companies, insurance companies, And our government and our regulatory agencies need to be aware of the importance of this growing pandemic, its complications, and how many lives can be saved, and how much costs can decrease if we treat it early. So first, it starts with awareness, education, and that's why the seminars are so important. So thank you very much.
No, thank you so much. And Dr. Theodore, beyond healthier lifestyles, how is obesity being treated from a pharmaceutical perspective? Dr. Solis Herrera just mentioned some of the things that are available, but would you like to add to that?
Oh, absolutely. And I think what you're hearing from both Carolina and from Amon is the complexity of the condition of obesity and metabolic disease. And it is a mistake to assume that it's an issue of calories in versus calories expended, simply speaking. So from a pharmaceutical company's perspective, to have a nuanced understanding of patient segmentation, of understanding the genomics of obesity, to understand sort of a precision medicine approach so that we continue to develop therapeutics that are best matched to the individual patient or population of patients is necessary. And the only way to accomplish that nuanced approach to metabolic disease and obesity is, as mentioned, to have access to data and to drive the best available clinical research and engage patients in that process of understanding metabolic disease and obesity, so that we can ultimately develop the best next-in-class therapeutics to address what has become truly a chronic healthcare condition facing Americans and, as you mentioned earlier, the global population.
And, we find that our populations, both Latinos and African Americans, have some of the higher rates than our non-Hispanic white population. And we tend to kind of live in the South, so the environment, the climate, all of these other kinds of things contribute to it, but also our lack of representation in clinical trials to make sure that these new available drugs are as effective in our population, I think is critical. Any thoughts on that? In terms of their participation in clinical trials.
Absolutely. I think what you're speaking to are the importance of the non-medical or the social drivers of health and how those also have to be included in our clinical trials. So it's very important for us to make sure that the representation in clinical research is broadly inclusive. And that is really core to a successful drug development strategy and ultimately critical to reaching as many patients as possible. And to your point, reaching those patients for whom the need is often the greatest. So I really appreciate you pulling out this issue of a deep understanding of the social drivers, the non-medical drivers of health that underlie metabolic and type 2 diabetes as a disease.
Thank you so much. I'm going to ask Dr. Hunter, you have a very personal story to share with us. You've actually lost 100 pounds through diet and exercise. Will you share how you went about this?
Sure. I remember kind of that change moment very, very vividly. One of my things that I really love to do is travel, nationally, internationally. It's just learning about new cultures. And so I remember one time, this was when I was, I would say, between 350 and 360 in terms of pounds. I was getting on the plane, and I had that moment when I had to put my seatbelt on and realized that it may not fit, right? And how uncomfortable it was, and then you had different looks from people that were walking the aisles. All of us have been in that, and sitting on a plane. And so I recognized at that point, hey, I need to make a change because this is affecting my quality of life. I want to make sure that I live a long and healthy life so I can travel to more places and enjoy my family and my community as much as possible. And so really it was about really two things I would say contributed to success. And this is also what we focus on in our health education workshops. First thing was I made a intentional effort to get myself educated. Prior to that point, I wasn't really knowledgeable about nutrition and the best ways to eat or even health and fitness and how to really get physically active in an effective way. And so, I went to websites. I talked to anybody who would listen. I talked to a registered dietitian. I found myself a personal trainer. And really, it was just an intentional effort. I need to learn about this because I want to make sure that I can lower my weight and again live the quality of life that I know that I deserve and so many people deserve to live. The second thing that was really critical was the support aspect of that. I didn't have friends and people around me that necessarily were trying to live a healthy lifestyle. And so I had to find those new friends, new acquaintances, start attending different events where I could get people that were like-minded, that were also trying to lower their weight and maintain a healthy lifestyle. And so once I had those friends that were going in the same direction that I was, it made that process a whole lot easier. And so that's my biggest advice to those who are looking to lower their weight beyond the recommendations that have already been given. Really educate yourself. Be knowledgeable about what are the new interventions that are available to you, and knowledgeable about what resources are available in your community, and then seek out that support. And like I mentioned before, we have some great workshops where you can meet others who are also trying to prevent or delay type 2 diabetes, who are trying to lower their weight and trying to better manage their chronic disease.
Well, congratulations to you and being such a wonderful role model for all of us. We've got some great questions that are coming in through our chat as well as email questions. And one of them was, Dr. Cancino, are you using a patient-centered approach when you have an individual who comes to you for help? And how do you design that?
Oh, that's a really great question. Yeah, our faculty at UT Health, something that's really important to us, really for any chronic disease, and obesity is a chronic disease, is, we want to first use person first, non-stigmatizing language. Each of our primary care locations is an NCQA recognized patient-centered medical home. And that's really, in a nutshell, we sort of design the healthcare we deliver with the patient in the middle and trying to create an experience for that patient that meets that patient where they are. And so that's the first thing I would say. The second thing I would say is, like anything else in terms of treatment of folks with obesity or with diabetes, this is a collaborative process. And so we need to understand where patients are first before we can kind of enter into their life to help them make the changes that are necessary. And so we want to utilize shared decision making, but also at the same time, be motivating. And to understand what motivates each patient, we need to understand where the patients are starting from, because everyone's journey towards treatment for diabetes or high blood pressure or obesity, everyone is at a different starting place. So to answer your question, that's how we do that. It's built into our system here, and it's really important because it leads to success.
Thank you so much. I have another question for Dr. Solis Herrera. What are your thoughts on whether obesity is a symptom of metabolic disorder or the cause of it? And the second part is, how far could you differentiate between the two with tipping the scales of this epidemic?
Yeah. Well, thank you for your question. And it's a fairly common question. So we used to hear this term of the metabolically healthy obese patient, but there's no such a thing. So obesity is a chronic disease that has complications that needs to be treated. And so those complications can be metabolic, diabetes, hyperlipidemia, etc. It needs to be treated like such with long-term therapy, long-term support to the patient. So I hope that answers the question. And also to understand that at some point, because I saw in the chat, there is a plateau effect. And that plateau effect is like lowering blood pressure with medication. You need to continue on the medication so that you can keep it under control. The moment that you stop the medication, you regain the weight. So those are important things that we need to know. But yeah, obesity is a metabolic disease, chronic metabolic disease itself that has complications. It's not a symptom.
Great. Thank you so much. Dr. Theodore, another question is from our audience is that the medications are expensive and they're expensive over a long term, especially for vulnerable populations. Do you have any of the medication treatment plans that, that can be a little bit more cost effective, or is there anything new coming out that other individuals can maybe hope for?
Well, thanks, Emily. It's a really important question, of course, and it's top of mind for anyone that's either providing care or developing new therapeutics or themselves are battling with issues related to metabolic diseases, is really the affordability of many of the therapeutics. And I think there's a couple of parts of the equation, and one is really the cost of mismanagement or non-management of obesity as well. So it's incumbent upon us in both the pharmaceutical industry, but also healthcare systems to analyze very carefully what the overall cost is of addressing metabolic disease and then balance that against the high cost of the therapeutics. So as we continue to do clinical research, it's also important for us to engage in health economics and outcomes research as well, so that we really are bringing maximal value both to patients and to their providers and to the healthcare systems that are responsible for these very high costs of care. It would be tone deaf not to acknowledge that there are significant expenses associated often with therapies, and that's why often pharmaceutical therapies are part of a broader approach from exercise and diet and psychological care and so forth, all of which come together to try to drive down the total cost of care and the total expense to both the patient and to healthcare systems providing care for them.
Thank you. And several pharmaceutical companies are are trying to have special plans, right, to help you reduce the cost. You just kind of have to negotiate with your pharmacy, where you're getting these medications too. So, but still, we need to do more, and hopefully they'll become more cost effective so we can reach larger populations. Dr. Hunter, there's a question here. What are your thoughts on how health at every size and body positivity movements contributes to solving or hindering the obesity epidemic?
Well, that's a great question. One of the things that is a very common question that we have, and it kind of took me off guard with that question a little bit. But it's important. We believe it's important to make sure that you are healthy and that you're getting that information, those resources to maintain your health. We know obviously we want to make sure that whatever program that we are offering, that we are inclusive of all bodies and communicating to all walks of life. One of the things that we often hear from people that are looking for information about our program is, hey, we don't want to change. I love my culture. I love the things that I eat. I love the cultural experiences that I have here in San Antonio. And so if this program is going to keep me from certain things, then we don't want to go there. And so really our approach is to honor everybody where they're at, right? It doesn't help when if your message is, hey, you have to stop this, that, A, B, C, etc. But we really want to be able to engage people in the conversation about health. And so the best way to do that is to meet them where they're at in that moment. And I think there's some nuance there, right? And so obviously we don't want anyone to feel their self-esteem to be hindered, and we don't want anyone to feel neglected, rejected, because of any state of life that they're in. But we do want to highlight what the research says. We do want to highlight what the dangers of obesity, of chronic disease are, and be very frank and very clear about that. So I think it really, I think it's a nuanced approach, and one that you are saying that, hey, you are valuable as a person, right? That your weight doesn't determine your value as a human being. But however, it also, also there is a danger. There are dangers there, as everyone else on the panel has said, in terms of for obesity. And we want to make sure that you have the tools and the resources in order to manage your weight effectively.
No, and that's great. And then you've also said the importance of just education, and the work that you are doing with the boots on the
Right.
ground in our community is so important. And it wasn't really until Oprah Winfrey had her special show on obesity and bringing to light that it was an issue, and it's just not something that happens to individual, but it's a health issue, and to be able to seek out help where you need it. So thank you so much. Dr. Solis Herrera, can you talk a little bit about the impact of hormones and how that can change? And just as we age, people tend to get more sedentary, put on more weight. What happens there? And then we lose muscle. So it gets complicated. It's just not so easy to say, oh my God, where did
Absolutely,
these 10 pounds come
absolutely.
from?
Exactly, right? So yeah, I mean, we're human beings, and we're dynamic, and our metabolism is dynamic. And just like during adolescence, you can gain weight and have multiple hormonal changes. As we age, it's a very important topic about metabolic disease and aging, and especially in women. So one of the things that happens is that you become more insulin resistant. You can be have more chances of developing diabetes, for example. But also our basal metabolic rate, the amount of calories that we're burning in average, goes down as we age. And so sometimes we need to exercise a little bit more, eat a little bit more protein, make sure that we don't lose muscle, a little bit more weight-bearing exercise, and keep an eye on our health. Go to our primary care doctor, make sure that we check ourselves, because there's a large part of the population that hasn't seen the doctor in the last 12 months. They haven't checked their A1C, they haven't checked their weight. And so those things are important to bring awareness to the population. Check yourself and make sure that you stay healthy.
There's another question here for you in terms of, some of the medications, and you mentioned this begin to plateau, but kind of what are the difference between Mounjaro and Ozempic and the different drugs? What do they really work on?
Right. So great question. In the first 6 to 12 months, it's the time frame when you are more successful to lose weight. All of these drugs are from the same family, both Ozempic, Mounjaro, or orforglipron, which is still in the pipeline, retatrutide, which is a triple agonist. All those drugs, what they do, again, they act on the central nervous system. They help us regulate our appetite, slow down our stomach. We eat less. But no matter how you lose weight, diet and exercise, adding medication, or even bariatric metabolic surgery, you will hit a point where the body starts stabilizing, because it is a defense mechanism of our body to stop the weight loss. And that is when you need to continue the work, you need to continue the medication, because your body will always secrete hormones to try to regress to that set point in your brain of your older weight. And so it is a long-term job that needs a multidisciplinary team. However, there are studies up to 2 years on the newer medications, where people, if they keep doing the work, taking the medication, they slowly plateau and continue losing weight a little bit slower than during the first year, but they can continue to lose weight. And just a brief comment regarding costs. Costs are already coming down. There are multiple programs on the pharmaceutical companies where it's more affordable to get the medication out of pocket if your insurance doesn't cover it. But also now we have good news from Medicare that will start covering obesity in patients that have established cardiovascular disease, which is the population at the highest risk. And also as all these other molecules come to the market, prices will go down, semaglutide will become generic. So there's great hope and a great future for treatment of obesity.
Good. That's good to hear. Good, good. Thank you so much. I appreciate that. Great. Dr. Cancino, I'm going to ask you one more question, and then we'll transfer to a set of different questions for each of you as we're coming close to the close of our time. But Dr. Cancino, when do you recommend a patient for bariatric surgery?
Yeah, that's a really great question, Dr. Ramirez. So number one, and I think we've touched on this, is weight management, weight loss is really effective when you're sort of part of a multidisciplinary team of experts in this field. And most of the time that that means a primary care physician, maybe a registered dietitian, a behavioral health consultant or clinical psychologist, an endocrinologist like Dr. Solis Herrera, and nowadays sometimes even a bariatric surgeon. There's a lot of evidence to suggest that for some folks, surgical therapy might be more effective long term than non-surgical therapies. And for patients to come to that conclusion, it's really important to talk to your primary care physician about that. Secondly, there are financial barriers often to bariatric surgery, and many employer-based insurances or private insurances might have some limits on what's actually available. So to answer your question, Emily, I think it depends. It depends on sort of where the patient is at, what their insurance coverage might be, and how engaged they are on some of the other traditional therapies of changing behavior, medication management, diet and exercise. But that depends. But that being said, for instance, at UT, and I'm sure folks are listening from across the country around this, there is a lot of strong evidence around bariatric surgery and its impact on chronic disease long term. We're very lucky here to have Dr. Rich Peterson, who's a national leader and expert in bariatric surgeries, to kind of bounce cases off of. And sometimes it's often just worth a conversation, if nothing else, between a patient and a bariatric surgeon to understand both the risks, benefits, and outcomes of those types of surgeries.
Great. Thank you. Thank you. Well, y'all have been fabulous. And I just want to end with a question. As science is kind of being challenged and why science and education are so important. And I'd like for each of you to maybe give me your thoughts on why is it important to educate the next generation of endocrinologists, scientists, public health, and community leaders about diabetes and metabolic diseases. So I'll start with Dr. Theodore. Let's start with you. I'll go to then Julius Hunter and then Dr. Herrera.
Yeah, I don't think you can overemphasize the importance of adequate education among clinicians, among medical students, among the patients themselves. And ultimately that effort in education, and I think many of us on this call would say that we're constantly in a process of education, even as clinicians and drug developers. It's a rapidly evolving space. So emphasis on education, both at the clinician level, the healthcare system, and also at the patient level. And lastly, as we come to a close, from my perspective, I want to draw attention to something that Julius mentioned earlier, the importance of community, that the patients themselves are not in isolation, and their outcomes, the response to therapy, the overall improvements that we all seek to find, best are accomplished when we create communities and a sense of inclusion and belonging. So I think some of the education initiatives that you referenced, Emily, at the end of the day, largely result in the sense of inclusion, belonging, and a sense of community.
Great. Thank you so much. Dr. Hunter.
Yes, education we know is empowering. As you mentioned before, I just recently got my PhD, and one of the findings of my dissertation research, the research looked at the relationship between body mass index, positive psychological capital, and authentic leadership. And one of the findings was that BMI was a predictor of hope. And hope was defined as having a sense of agency and also having a sense that there is a pathway forward to meeting those goals. And one of the most effective ways of increasing hope in a population is really providing them with the facts, with the education that is needed in order for them to make decisions so that they can change whatever it may be. Obviously, we're talking about health, but so they can make decisions to really manage their health appropriately. Also, that education lets them know and gives them a hope that, hey, I can see that this is possible. I think a lot of times people in our communities don't realize that, hey, there are resources around you to help you to really make those changes in your life. And though you may feel like it's a hard thing, right? And it is true, behavioral change is hard. But we want people to know that through UT Health, through the city of San Antonio, that there are, and many other organizations that are here working in our community, there are resources to help you better your life, to help you to have a better quality of life as you manage your weight, as you seek to prevent chronic disease, and as you better manage diabetes.
Beautifully said. Thank you so much. Dr. Carolina Solis Herrera, your last thoughts on this, and then Dr. Cancino.
Well, thank you very much again for the opportunity. And I just want to bring up the success of this event and disseminating the information and spreading the knowledge. I see that we have people not only from all over the country, but also from multiple countries, including Mexico, Ireland, etc., that I can see here. So it's extremely exciting that our voice can get out there. And please remember, be disseminators of information. Open the conversation with the patients, be their cheerleader, just like Dr. Hunter said. Patients get really motivated when they see results, and then you need to help them keep that motivation going, because it's not a sprint, it's a marathon. And it's a marathon that we are willing to run with the patients and stay with them for this long journey. So thank you very much for the invitation, and happy to answer any other questions.
Great. Thank you. Dr. Cancino, wrap it up for us.
Yeah, so I'll kind of bring it home, but I'll maybe end on a more sobering note. Is this epidemic continues to grow, right? The growth curve of obesity and diabetes in the country might be bending a bit, meaning improving a bit, but it's continuing to grow. So to answer your question, we need to bridge the gap between science and implementation. And so we need scientists to innovate. We need public health professionals to scale prevention. We need community leaders to build trust with communities. And the reason we need to educate future generations is because it's future generations that are going to shape policy and practice in our community. And so, again, we're biased because we're at UT and we're sort of coming from an academic setting, but I know communities that would benefit from the next generation of leaders who are coming up. And so I'm really excited for the future based on things that Dr. Solis Herrera said and things that were discussed here. But we need to keep working because the epidemic continues to grow.
Right. We need to keep working. We need to make it accessible to all our populations. And that's what we most care about, so that we can make a difference for everyone. Well, thank you, each and every one of you. Thank you, Genentech, for this opportunity. You all just did a beautiful job. And for those who were listening today, thank you for joining us. And we'll answer any questions that we didn't get to. But thank you. You all have a wonderful day. Look forward to our next one. Take care.